So welcome everybody to tonight's meeting. As most of you know who have been here before, the purpose of these sessions is to try to educate the public on kidney disease, both to help yourself and to help your friends and loved ones. And tonight we have the special honor of having Dr. Farid Armani. He's one of our outstanding nephrologists at UCLA. And tonight he's going to be talking about a very important topic, and that is when your kidneys ultimately fail, one of the choices you have to make is whether to have dialysis and also what modality to have, whether it's hemodialysis, peritoneal, or you may choose with your doctor that you don't want to be dialyzed. So Dr. Armani is going to be discussing this very important topic with us tonight. So Farid, thank you so much for taking the time. It's a great pleasure to have you. Thank you again.
Thank you very much, Dr. Kurtz, for your kind introduction and for having me. And hello, everyone. As Dr. Kurtz mentioned, I am one of the nephrologists at UCLA. I have been a faculty here for about 1 year and a few months. I finished my training last year in my beloved New York and Columbia, and I joined faculty at UCLA, and I'm honored to be here. For today's topic, I decided to talk about dialysis because being a faculty for almost 1.5 years now, I realized that this is a topic that is very uncomfortable for most patients to talk about. And talking and learning about dialysis gets pushed off because people simply don't want to think about it. And we have this reaction that we think if we talk about something, it's going to happen. We push it off. And then eventually we get to the point that decisions become imminent, but not enough discussion has happened. So because of this, I wanted to today talk about living with end-stage kidney disease. I talk about hemodialysis, peritoneal dialysis, and also the option of choosing not to do dialysis at all. So these two little organs are our kidneys. These are how they look like in real life. This is a very brief introduction I'm going to give you about our kidneys. This is a cross-sectional image of picture of the kidney as illustrated. When you look at it, it is actually looks quite simplistic. There is one blood vessel that brings the blood to the kidney, another one that takes it out, and we also have this ureter that takes the produced urine to the bladder. All of these are kidneys functional units or calyces, and this is where the action happens inside the kidney. We have usually two of them. Not everybody has two kidneys, and in rare occasions, patients might have one or might have more than two. These are very rare occasions. They are usually in your back under the rib cage. Sometimes they don't go up there all the way under the rib cage and they end up in your pelvis. About 4 to 5 inches long. Each one is less than a pound. It's about 150 grams. And that 300 grams of your flesh receives about 20 to 25% of your cardiac output in any given minute to clean it up from all the toxins that your body produces during the day. This is a glomerulus, one of my greatest interests in life and how it works in the kidney. This is a filter that receives your blood. We have about 1 million of these in each kidney. That's a rough number, has been counted between 600,000 to 1.5 million in each kidney. This filter receives the blood, and inside this filter, the blood is cleared. A urine is produced, which flows into this space and goes to the rest of the kidney. But cleaning the blood is not the only function that the kidney has. Kidney is kind of like a gland, an endocrine gland. It receives signals from the body in forms of hormones, and also it makes some hormones. One of the important ones is something called erythropoietin. Our kidney senses when our red blood cell count is low and makes a signal that travels in our blood and goes to bone marrow and they send a signal to the bone marrow to make more red blood cells. Our kidney also is in charge of activating the vitamin D that we eat in the food. Vitamin D has active and deactive forms, and we eat the deactive form. Our kidney activates this, and this sends signals to our body to reabsorb calcium and helps our bone health. And finally, the kidney senses our blood pressure and sends signals to our blood vessels to modulate our blood pressure. If it is low, try to bring it higher, and if it is high, try to bring it lower. So kidney is not just a cleaning machine. It has many different other functions. Some of them we are starting to know, and a lot of work has gone into this, figuring out exactly how it works by likes of Dr. Kurtz, who has done a lot of extremely valuable work in helping us understand how the kidney works. Kidney disease is quite common. It's been estimated that around 30 million people in the United States have a degree of kidney disease. The most common culprits and risk factors for kidney disease are listed here. Diabetes is by far the number one. High blood pressure can damage the kidney. There is always this debate on whether high blood pressure is damaging the kidney or kidney damage leads to high blood pressure. As we age, we all lose some of the kidney function. As I mentioned, we are born with 1 million filters in each kidney. These filters do not regenerate. As we age, they start dying off at different rates, and they do not regenerate. So it is anticipated that our kidney function will slowly go down as we age. Obesity is a big question. Nowadays, we are starting to recognize it more and more as a risk factor for kidney disease. Smoking is a big, major risk factor. In my opinion, it is almost equal to diabetes in terms of causing harm to the kidneys. Family history is important. About 20% of the patients who have kidney disease will have a family member who has been diagnosed with kidney disease. Some of these are what we call monogenic disorders, meaning that if the parent passes the gene to the children, they will have the disease. Some of them are more complicated. And also cardiovascular disease, if the heart is sick, the kidney is not going to be happy. The same goes with liver. Kidney, heart, and liver have this axis that they kind of very closely cooperate with each other. And if each one is sick, the other ones could get unhappy as well. I am sure you have heard this before, that the kidney disease is a silent disease. In early stages of kidney disease, the patients do not have any symptoms. The most common thing I hear from my patients when they come to see me for their first visit is that, oh, I am feeling fine. I don't have any symptoms. I just don't know why my blood work is showing abnormalities. Most commonly, it is picked up on routine blood work, on your physical, and usually your doctors pick up that there is a signal that the kidney function is declining, and that's when they decide to send you to see a kidney doctor. It is usually a progressive disease, meaning that once it kicks out and it starts, it will gradually going to get worse over time. This is not always the case, but for majority of cases of kidney disease, especially if they are the ones associated with other chronic conditions, like diabetes and high blood pressure, the kidney disease is going to progressive. And a lot of times what we do is trying to preserve the kidney function. It's also important to note that in the vast majority of the cases, the kidney function that we lose is lost irreversibly, and it is not going to come back. So we focus on preserving the remaining kidney function. It is not always the case, but it is the case in most patients. When you look worldwide, 44% of the kidney disease is thought to be due to diabetes. That's close to half. About 29% is due to high blood pressure. Polycystic kidney disease is a genetic disorder which runs in the families, and that accounts for about 2% of the patients with advanced kidney disease. Glomerular diseases, which is the area of my interest, which is basically the diseases specifically to the filter that I showed you, account for about 7%, and 18% are other, which means that we simply do not know yet. We have caught the patient too late to be able to figure out what happened, or our science and technology has not progressed enough to pick up these cases, the etiology of these cases. Important to note that once kidney disease enters the end stage phase, the symptoms start to develop. There is a test called creatinine, which is used to kind of calculate or estimate the kidney function. And when that number drops below 30, which is commonly referred to as the percentage of kidney function, symptoms start to develop. These symptoms start and progress slowly, so slowly that sometimes the patient doesn't even feel they have any symptoms. It is common among my dialysis patients that right before starting dialysis, they tell me, "Oh, doctor, I'm feeling fine. I don't feel any different." And once we dialyze them and we take away all the toxins that have accumulated in their body during that time, they notice the difference and said, "Oh, yes, I feel so much better now. I just didn't even know how bad I was feeling." And that's because as a species, humankind is very good at adapting to everything, including the negative symptoms that we have. These are some of the symptoms that can develop with end-stage kidney disease. The most common ones is a nagging sensation of nausea. Sometimes it's persistent vomiting. A very bad taste develops in the mouth. People describe it as a metallic or sour taste. Sometimes it's just, the patient says, "Oh, the food is not tasting the same, and I have lost my appetite." Fatigue kicks in. Itching is very common. The toxins that accumulate because the kidney is not working can lead to skin itching. Patients can develop fluid retention, meaning that the kidney loses the ability to get rid of the sodium or the salt that the patient eats during the day and the water that goes in, and they start to accumulate and they develop swelling, especially beginning with the lower extremities. Chest pain and shortness of breath can develop just again because of that fluid that's accumulating this time in the lung. Muscle cramps are common, and bone pain is common, which is because of the lack of active form of vitamin D. Once these symptoms develop, we need to start talking about starting dialysis. But it is not only about the symptoms that the patient is experiencing. We do monitor the patients with end-stage kidney disease very closely. We do blood work. I personally see these patients close to dialysis monthly because we can find a lot of abnormalities that are not causing any symptoms like high potassium levels or low calcium levels, but they can actually be life-threatening and need to be dealt with. Anemia can develop just because of the hormone that I told you that the kidney is losing the ability to make. Blood acid levels can go up and the phosphorus level can go up. We try to manage medically because we don't have any evidence that starting dialysis early is necessarily going to benefit the patients. But some of these things cannot be really treated with medical management. And when we get to that point, we need to make a choice about what to do next. The options to manage end-stage kidney disease are a few. Number one, and the most common one, is hemodialysis. And I'm going to talk about most of these one by one. Then there is peritoneal dialysis. Kidney transplant is an option that I'm not going to talk about. This can be from a living donor or a deceased donor. And again, this is not a topic of my discussion. My focus is going to be mostly on dialysis. And then there are patients that say, "I do not want to do dialysis at all. I don't want to go through that. I just want to stay comfortable even if that means that I'm going to die soon. In-center hemodialysis is by far the most common way of doing dialysis in the United States. About 90%, close to 90% of the patients in the United States receive in-center hemodialysis. In different parts of the world, it is different. There are places that have half and half, or even in Southeast Asia, we have countries that do up to 80% peritoneal and home dialysis. But for historical reasons, in the United States, close to 90% of our patients receive in-center hemodialysis. This is usually, most commonly, a 3 times a week treatment. Historically, it is done on Monday, Wednesday, and Friday, or Tuesday, Thursday, and Saturday. There are variations. Some people need less, some people need more. And every session of dialysis is between 3 to 4.5 hours. Again, that depends on patient size, their residual kidney function, and a lot of different factors. How it works is that the patient gets connected to a machine by 2 tubes. One tube pulls the blood, takes it to this filter, which is supposed to resemble the filter that I showed you. And this filter runs what is called a dialysis fluid that comes in, exchanges the toxins with the blood, and comes out the other side. And then the blood returns to the patient. The dialysis fluid is coming in touch, very close touch with your blood, so it needs to be processed very carefully. And that's actually a big reason that dialysis is such resource intensive, because we need to prepare that fluid very carefully. But in order to do all of this, if you look here, we need a way to access your blood, to connect to your blood. The most common way of doing this is an arteriovenous fistula. This is created by a surgical procedure. A surgeon goes in a 1 day, half a day's procedure that patients are usually go home after, a few hours after, connects a artery to a vein and lets it mature for some time. And after 2 to 3 months, that's ready to use for needles to go in. The other way of doing this is using a tunneled catheter. This catheter goes under the skin, turns around and goes into one of the big veins and gets very close to the heart, basically enters the heart, pulls the blood from this huge pool of blood in the heart, puts it through the machine, and sends it back. Fistulas are by far the superior access for majority of the patients. The risk for infection for catheters is simply too high. Whenever there is an external body, foreign body inside your body can react to it and can cause infection. And a catheter is a piece of plastic dangling around the heart or inside the heart. So that has a tendency to pull bacteria. Bacteria like to sit on it and become infected. So whenever possible, we try to get our patients to get a fistula instead of a catheter. This is a dialysis machine, and this is a traditional dialysis setup. There are chairs, reclining chairs. There are TVs available for the patient. The patient goes in, sits on the chair. A tech comes in, prepares the machine, connects the patient to the machine, and at the end of the treatment, just disconnect, and the patient goes about their day. The pros of this treatment is that this is entirely handled by professional staff. There is no need for the patient to work with the machine, with the dialysis access, with any tubes. And obviously, when you are on dialysis, you are being closely monitored by the techs and by the nurses. If anything goes wrong with the machine, they're right there on the scene. They can fix it. They can immediately reach out to your doctor. And a lot of people prefer this. They don't really want to deal with all of these things. They find it too complicated, too much for their lives. But it is not all about pros, right? This is basically taking almost 3 days away from normal life. For people who want to continue working, this can prove very challenging. Yes, there are dialysis shifts that are very early, 2, 3 in the morning, or very late, 7, 8 at night. Even there are ways of doing it what we call nocturnal, which starts midnight to almost morning. But this is not really the normal sustainable life. Also, a lot of patients feel very tired and fatigued immediately after dialysis and basically go home and sleep. So that people who really want to maintain a productive life, that can be challenging. Then there's an issue of transportation 3 times a week to a dialysis unit. And just a reminder that our kidney does not work like 3 days a week. Our kidney is awake 24/7 and cleaning the blood. So when you condense and jam all that clearance into three-hour sessions, you're doing a lot of shifts in the toxins. And some people, they might it pretty harsh in the body, on the body, especially in the elderly population. And that's the reason that a lot of people resist to the idea of dialysis, because they see the patients and they feel like they are basically worn off after each session, and they feel like they don't want to look like that or deal with that. There is a way of doing the same type of blood dialysis at home called home hemodialysis. This is a little less efficient than doing it in center. So almost everyone who is doing this needs at least 4 to 5 treatments a week at home. It's the same principle of how it works in terms of cleaning the blood, but the machine is smaller, less efficient, so it takes more hours of cleaning. The technology is scaled to run at home. This machine you are seeing here is the most common machine that we use in the United States for home dialysis. That's a blood filter that you can see. Here you see a bag. So the dialysate, which, as I mentioned before, comes in close contact with your blood, is prepared in form of these bags that you will need to hang to the machine, set up the machine, set up all these connections, and connect to the fistula or the chest tunneled access to run dialysis. This is by far the most common machine. It has some pros, some limitations. The biggest pro is that it is portable. So if somebody wants to travel, they can actually take their machine with them. And it doesn't connect to any home faucet or home water. It doesn't use your water. The bags come prepared, but also these bags, every dialysis treatment will need about 4 to 5 of these large bags, which are, everyone is like 10 pounds. And the usually supplies get shipped to the patient every 2 weeks. So you will need space to store all of those boxes. This is a newer machine. This is called Tableau. This has FDA clearance to use with dialysis. The first thing that jumps to you is that this is not portable. You are not going to be able to travel with this. But it has a lot of pros. This machine actually generates the dialysis fluid here under this area, and you don't need to store the bags. This machine gets connected to a faucet, and then these two containers are put on the machine. It has a very intuitive interface, which is very nicely done and walks you step by step exactly on what you need to do every step to set the machine up, put this cartridge in, put that filter in, and then start dialysis treatment. It is a little bit more efficient than the previous machine that I showed you, and it is gaining traction. Again, it has pros and it has cons. And this is another new machine. This is also cleared by the FDA. This can run off bags or run off the dialysate that it produces. Currently, for the United States, it's clear to run off dialysis fluid that it produces. So again, not practical for traveling at this time, but a newer machine and more intuitive to work with. But as you see, this takes a lot of work to set up. What are the pros of doing home hemodialysis? The patient stays home. It can be done at night when you are sleeping. You can just hook yourself up to the machine with the help from a family member, go to sleep and wake up in the morning, disconnect yourself, go about your day. Again, it is much gentler than the in-center hemodialysis on the body. It's easier to tolerate. So if the patient is frail, they have a lot of other diseases, this is much easier to do. The patient feels much better. The cons are that there's a lot of involvement from the patient and the family. Usually the family is the one that has a little bit higher burden than the patient. There is a possibility to hire a nurse, but that is not going to be covered by the insurance. So it can be very pricey. A lot of people opt to learn and do it themselves, and that learning is a steep learning curve of about 3 months of treatment in dialysis center by trained staff before you can transition to actually home. As I mentioned previously, you can do dialysis with a fistula or a catheter. If you are using a fistula, some people are very uncomfortable with the idea of sticking themselves with a needle or having a family member sticking them with a needle. And you are not in a dialysis center. There is not a nurse or a tech monitoring all of your signs. The machine alarms can give you a lot of anxiety if you don't know what to do with them until you call a nurse and ask for them for help. The newer machines, the two that I showed you, are very well connected to internet. So it is possible for the doctors or the nurses to at least see what exactly is going on remotely. But that is not going to be similar to being in a dialysis center and being monitored. However, this modality works very well for a certain population of patients. For example, if somebody is on the older side and they're frail, they don't feel like they can go to dialysis 3 times a week, but also don't feel comfortable with the peritoneal dialysis, which I will explain next, this can be used and offered, and it works pretty well. The next modality is peritoneal dialysis. This is one of my favorite modalities to do dialysis. Turns out that besides that 1 million filter in each kidney that I talked about, we have another giant filter in our body, and it hides in our belly. Our belly membrane can be used as a filter to do dialysis and clear our blood from the toxins. And that's the idea that was basis for doing peritoneal dialysis, which started about 50, 60 years ago. The idea is that a catheter goes inside your belly. A solution, dialysis fluid, which comes in form of bags, goes in. This white membrane here is used to clear the blood of the toxins. The toxins accumulate in this fluid and then come out and go to a drainage bag. This is not the way that we do it in the United States. This is the manual way of doing this. We do this with the machine. The catheter itself kind of looks like this when it goes inside. It is placed by a surgeon, and it is usually ready to use 3 weeks after it's gone in. So if somebody needs imminent dialysis to stay alive, this might not be the modality to do. There are some studies trying to use this as urgent way of doing dialysis, but if you put the catheter and immediately start using it, there might be complications and it could fail. So it is not favored at this time until our techniques of placing the catheter inside evolves a little bit more. In the United States, we typically, for most people, use one of these machines to do the dialysis. This is the footprint for the machine. It is, again, portable. You can travel with this. Dialysis bags are set at night here on the top of the machine and on the side. All the connections are connected. Usually, then the patient is hooked up to the machine. A person who has enough dexterity and ability can do it themselves or can ask for a family member for help. These tubes are quite long, so patients usually hook themselves up. This is an 8 or 9 hour treatment and usually happens 5 to 7 nights a week. You go to bed, you wake up in the morning, treatment is done, disconnect the machine, and you have your day. And it is done so gentle and so easy on your body that usually is much easier to tolerate than in-center hemodialysis, that when the exchange happens, the patients don't feel anything different. So with peritoneal dialysis, this is another way of staying home to do dialysis. It is most commonly done overnight, so you can keep your day-to-day life. This is the modality that a lot of people who work choose because they can have their day to themselves, and it is very gentle and tolerable. The cons, again, are that There is a lot of involvement from the patient or family. The dialysis fluid will be shipped to you, so need to be stored. The catheter is inside the belly. Some people really dislike the idea of a plastic piece dangling out from the belly. If you have a pit, the pit cannot be anywhere close to the machine or the supplies. We used to basically refuse any patient who had pits at home for peritoneal dialysis. Now we are more flexible. We accept patients with pits, but the pit space needs to be 100% separate from dialysis space. And there is risk for infection. There's always risk for infection when you connect something to your body, either with fistula or with catheter in the chest or catheter in the belly. However, this is a little higher. And the risk is that if the infections keep happening and happening, that belly membrane can burn out and peritoneal dialysis could fail. Other things that we manage during dialysis, going back to the picture that I showed you again, kidney has multiple functions. It is not only cleaning the blood. We manage the anemia because that hormone, the signal is missing. So we have produced that signal in the lab since 1990s, and we give that shot with dialysis to stimulate the bone marrow to make more red blood cells. Iron deficiency is very common in dialysis because dialysis patients use a lot of iron and break it down. So we give iron a lot. We give active form of vitamin D that doesn't need the kidney involvement to protect the bone. And phosphorus is an element that is in our food very commonly, and it is cleared by our kidney. But when the kidney function stops, we can't clear the phosphorus, and we end up giving you and the dialysis doesn't clear phosphorus either. So we give the patient phosphorus binders, which they take with their food to bind to the phosphorus in the food and put it in the stool and get rid of it. And finally, the last piece of my talk, I'm going to talk about what if the patient says, I absolutely do not want to do dialysis. At this time, first of all, every patient has every right to make that decision. This is a big decision, not the easiest treatment in the world. It is important to note that vast majority of patients who decide not to do dialysis, when the kidney doctor tells them it is time to start, not based off numbers, not based off symptoms, but when the doctor tells them it is time to start, will die soon. And about 90% will die within 6 months. Could be faster, could be days, could be weeks. There is a branch of nephrology started recently in the past few years called palliative care nephrology. For this one, we focus on comfort, not extending life with doing dialysis. We manage symptoms like nausea and vomiting, itching, and some of the fluid buildup. End-stage kidney disease is painless. Nowhere along this process of kidney disease you should feel pain. So we don't focus on pain, which is a big topic in palliative care when it involves the cancer patients. But in our case, we don't really deal with pain. We basically use all of the meds that we have at our disposal to keep the patient comfortable, knowing that without doing dialysis, they will die soon, but we respect that opinion and respect that decision. And just a few points to take away. Know your options, please, and I hope this is what you will take away, and advocate for yourself. Unfortunately, historically, the way dialysis has been set up in United States, most people will end up on in-center hemodialysis without even knowing their options. There are a lot of historic causes for this, which I'm not going to get into, but you need to be your advocate. You need to know about different ways of doing dialysis. Talk to your doctor, and if your doctor is not able to give you the other options, then you might need a new doctor who is able to tailor the care to your needs and your wishes. I always recommend my patients with progressive kidney disease to make a decision about dialysis as soon as possible and share that with all of your loved ones. dialysis exactly how you want it to be done. One of the symptoms that I don't know if I mentioned with kidney disease, advanced kidney disease, is sluggishness and confusion. So as the disease progresses, a lot of people really lose that ability to coherently have a discussion and make a decision. So I prefer to have these difficult conversations as soon as possible to understand, to make sure that we are treating our patients the way that they want us to. If you are doing dialysis in center at home, know your dialysis doctor's name if you are opting to do dialysis. Your dialysis doctors are the ones that are managing a lot of aspects of your care and keeping you alive. And a lot of time, I see patients in the hospital, they don't even know what their doctor's name is. That's because of the nature of it. You go to dialysis 12 times a month. A lot of times doctor's visits can be 10, 15 minutes per month. You might not even remember the name, but it's really important. In hospital, if somebody goes in, they will ask them. And just probably most important doctor in your life will become your dialysis doctor, who will coordinate your treatment and will coordinate a lot of other aspects of your care. And then finally, if somebody is approaching dialysis, consider home dialysis options if it is a possibility. It has cons, it has downsides, but also it's a great way to stay home, keep an active life if that's what you wish, or for the frail patients who don't like the idea of going to dialysis centers 3 times a week, to stay home and spend more time at home with family. With that, I will end my talk. I thank you very much for your time.
Thank you, Fareed, for an outstanding talk. Perhaps I can start off by asking a common question, and that is, do people do better on peritoneal than hemodialysis? Do you live longer? Is it better for you as a renal replacement therapy? What, if you have a choice, and even a choice of home modality for both, what would be a better option?
Yes, that's a great question, Dr. Kurtz. So there is data. Remember, when we start dialysis, the kidney has not completely died. Usually there is a little bit of residual function. There is data that residual function is linked to better survival. And there is data that doing peritoneal dialysis actually preserves that residual function a little better than hemodialysis for longer, meaning that you will make urine for longer time. And at least for the first few years, peritoneal dialysis seems to have better outcomes. If my patient is able to do peritoneal dialysis, that's usually the modality that I personally recommend. Home dialysis is also a great option, and I have certainly put my patients on home hemodialysis. There are certain patients, again, if I need to start dialysis as soon as possible, or peritoneal dialysis is not an option for a variety of reasons. For example, if somebody has had major abdominal surgeries, that might not be an option. My second choice is usually doing home hemodialysis, and in-center hemodialysis is usually the last thing that I offer, unless that's what the patient wants after hearing about pros and cons of each.
Thank you. And another common question that we hear about are people in their late 80s and 90s who either can't get to a dialysis, they're healthy, they're in a nursing home, but they can't get to the dialysis unit, or the family doesn't want them dialyzed because they have other comorbidities. How long can a patient live who's reasonably well otherwise, no problems with cancer or heart disease, but just can't get dialysis? Can you live a few years?
Not few years, unfortunately. In these patients, we are usually talking 6 months to maximum of 1 year. By 1 year, almost all of them will die.
So to medically manage the cardiac issues, the high potassium, the phosphorus, assuming they have some residual renal function, that they still
If there is enough residual function, might be able to extend it more, a little over a year. but that renal function needs to be substantial because not it's very not all of the symptoms and all the complications unfortunately can be managed without dialysis. So it can, but there are a lot of limitations.
Could you also discuss perhaps patients who are busy, let's say younger patients who are busy during the day but want to be dialyzed at night but don't want to do it at home? Are there any places in Los Angeles where you can get dialyzed in the evening,
That's a
or
great question.
even daily dialysis if you wanted to be more aggressive and not do it only 3 times a week? Are there any programs?
That is a great question. I actually have a similar patient, so I have explored this in depth recently, and I was able to find a couple of dialysis units that offer a very late shift, which starts after 6. I also found one dialysis unit in Crescent Heights that offers nocturnal dialysis, which is basically midnight to morning. That's a quite intensive and prolonged dialysis. The patients actually do pretty well on that type of dialysis. But yes, there are units. It is limited. Most places run 3 in the morning to last shift starts around 2, 3 in the afternoon, and by 5 or 6 they are closed. But there are definitely units here and there that offer very late evening shift or nocturnal dialysis. I found only one.
And just so the audience understands, for the nocturnal dialysis, are patients able to sleep on dialysis, or they're working and awake all day and then they have to do nocturnal at night and still be awake? Is it for the brave, or can people actually sleep during
No,
the day?
vast majority of dialysis, even during the day, sleep on dialysis. So they can the beds, the chairs recline, and majority of patients actually sleep during dialysis, even during the day. And nocturnal patients are also expected to sleep. Otherwise, it is not sustainable.
And another question is the side effects on hemodialysis. People in the audience and others often ask about cramping, or fluid shifts causing other issues. Can you discuss just briefly what is done for the cramping, which is a common problem?
Yeah, cramping is a big problem, and one of the limitations that we have with, especially with hemodialysis, that doesn't happen. At least in my experience, it never happens with home hemodialysis, and it never happens with peritoneal dialysis. It is because of the fluid shifts. We use different strategies in dialysis when we are treating the patients. Like we slow down dialysis, we slow down how much fluid we are removing. I personally also work with the dialysis temperature because we can change the temperature of that fluid that's running. That sometimes helps. We use all of these strategies, temporarily stop the fluid removal and resume it back. To be perfectly honest, it is not always successful. We do our best with these strategies. Uh, One thing, I mean, I didn't put it in there, but to say dialysis is not necessarily a benign, easy treatment. This is an important way of keeping someone alive. A lot of times there will be complications. We know it is not ideal. Kidney transplant in most patients is the better modality. It is not always possible for everyone to get one. But the cramping, the fatigue after dialysis, feeling worn off, these are the most common issues that people on dialysis deal with. We try our best to address, and we are not always successful.
And could you comment? Another question that comes up is there are people that are waiting for a transplant go onto dialysis. Is there any worry about how long they're on dialysis before the transplant? Does it affect how the transplant does, or can they be on dialysis for any length of time and it really doesn't affect what the outcome is of the transplant? It's a question that comes up.
Yeah, that's also a great question. The length of time on dialysis can certainly affect overall outcome and mortality. Again, dialysis is a pretty can be intensive treatment. Your body, your blood is not supposed to come in touch with an external foreign fluid 3 times a week. It is an inflammatory state. It comes with other slowly developing complications. There was the thought years ago that a certain percentage of dialysis patients die within 5 years, and that might be even higher than most cancers. So the sooner the patient gets dialysis, the outcomes are going to be better. The blood vessels that are inside you that are going to be connected to the new kidney are going to be healthier if you get it earlier. You have been in that inflammatory state for shorter time. Unfortunately, the wait times in the United States are quite long. In California, especially in Los Angeles, we're talking 7 to 10 years of wait time on dialysis.
And are there any studies comparing PD versus hemodialysis prior to transplant, whether the transplant does better if you've been on PD for let's X number of years versus hemodialysis for X number of years?
I believe there are a couple of studies. I can't recount on top of my head. With PD and the outcomes, the question has always been, is that because PD is better, or we are putting healthier patients on PD? That has been a big question, because if the patient is like frail and is not able to do PD, they're going to automatically go on hemodialysis. So there has always been this question of patient selection. But as far as I can recall from these studies, patients who have been on PD prior to transplant do better with transplant. Is it because PD is better or because the patients are healthier? Difficult question to answer.
And perhaps this question's a little off topic, but I'll ask it anyway. It has to do with CKD staging in people who are 80 and 90. Given that the GFR or the kidney function declines with age, the average eGFR in a 90-year-old is probably around 70 or the high 60s. Has anyone come up with different CKD staging for the 80 and 90-year-olds? In other words, a GFR of 70 in a 90-year-old doesn't have the same import as in a 20-year-old. And are the criteria for when a 90-year-old would need dialysis any different than a 30-year-old, given that the GFR has declined already just from nature?
A great question. This is a hot topic, an area that there's a lot of debate, and people are throwing out a lot of proposals. Currently, the standard that we use is by KDIGO, by National Kidney Foundation, and we are still using the same scale for all the ages. So hopefully that will be subject to a change, because a lot of work is being put into it. And answering the second part of your question, I mean, GFR is not the only factor that we look for offering dialysis. Numbers are part of it, and symptoms are the second part. So the decision to start dialysis is a comprehensive decision. Most commonly, we start when GFR is less than 15, typically closer to 10 or under 10, but that's only one of the factors. Our body has this wonderful ability that gains the ability to keep us equilibrated even in very low kidney function levels. So a lot of times people with GFRs of 15, 14, 13 are sustained and maintained, and we don't necessarily jump on starting dialysis. So we are still using the KDIGO GFR, but for elderly, for everyone, we basically look at the symptoms about the decision to start dialysis, not necessarily the single number.
Perhaps now I've usurped the question and answer period. Is there anyone on the call who wants to ask Farid a question? Don't be shy.
I have a question.
Yes.
If you go exercising and you're huffing and puffing, does that cause extra blood to be going to the kidneys? And would that be ill-conceived if you have kidney disease?
No, you will receive enough blood flow unless there is a patient with some sort of significant heart condition like heart failure, which that person will probably not be able to do exercise the way you describe. Exercise is actually very good, increases the blood flow all over, and we recommend it to everyone. not intense to everyone, but exercising is recommended, and your kidney will receive enough blood flow.
Thank you. Are there any other questions at all?
Guess I was more worried about too much blood. Can there be too much blood to the kidney?
No, it can handle it. It's like a sponge. We worry about too little.
Any other questions at all? There's a question in the chat. My mother-in-law lived till 97. She had 35% kidney function for about 20 years prior to that. Do you want to ask Farid a question?
Yeah, I'd like to ask a question. Can you hear me?
Yes, we can.
I was just wondering what your advice to people who are over 90, who have other frailties because of age. Is it still reasonable to do a dialysis? Or it's an existential question, kind of, is it really time? The costs aren't worth the benefits.
Yeah, that's a great question. That is not uncommon for us to see these patients. First of all, there's no single simple answer that fits everyone. It really depends on comorbidities and the patient's values and what they want. Honestly, like before doing nephrology and doing training in this field, I would have said probably it's better to just forego dialysis and focus on comfort. However, the home dialysis modalities, especially for the patient you are describing, like home hemodialysis, is quite gentle if the family and the patient is able to support it. It is not that hard on the body and it is tolerable, especially for more frail patients. And if the patient's values line up, and I mean, there are a lot of patients with their belief system that they really don't want to let any treatment go and they want to try and fight until the very last breath that they have, and we respect all the belief systems and the wishes. That is something that I think is close to palliative care. It is not that harsh and manageable. So there is not a single answer. I have seen patients who are 90 and above starting dialysis and buying themselves some time, quality time. But if the only option is in-center hemodialysis, I would definitely not recommend that. That usually doesn't go well. It is very intense and it basically adds to the suffering.
Thank you.
I think we have time for maybe one more question. If not, I want to thank Farid for a wonderful, wonderful talk. Thank you so much for taking the time. Oh, it looks like we have one more question.
Sure.
From Terry. Recent Kaiser study showed that 18 to 20% of patients in Southern California had chronic UTIs due to E. coli that was traced to meat products. Does chronic E. coli contribute to kidney disease?
Oh, I don't think I've seen this as a risk factor. Chronic infections that cause inflammatory state could, but I can't think of a direct link that I have read about. But that's a great question for Dr. Kurtz. Have you come across something
Yeah, I
like
think
this?
he's referring to chronic UTIs.
Yeah.
Chronic urinary tract infection. Can it
Yeah.
lead to a draw? I guess, the simple answer is if the infection gets up to the kidney, then it's not in the lower urinary tract, and if it affects the kidney tissue, we call that pyelonephritis, and then that could lead to more chronic kidney disease. But if it stays in the lower urinary tract infection, it shouldn't affect the kidney function.
I think they're probably referring to cystitis,
Yeah.
recurrent cystitis.
Okay, everyone. Well, thank you so much for joining, and thank you, Dr. Arman, for a wonderful talk. And we'll see you all next time. Thanks again for joining. Thank you.
Thank you for having me, Dr. Kurtz. Bye.